And I first discovered this even before getting into nursing when I was sick in Poland. And what happened is I went to a Chinese doctor and he took like a needle instead of like the glucose test, and he took a poke of my blood and he put it under a microscope to see the shape of my red blood cells. And he told me, long story short, appendicitis, and I was on long-term antibiotics, which for some reason messed up my not immune system, but my gut, which I had to treat naturally. So he literally looked at your your microbiology and told you what's wrong with your body, what are you deficient in, based on the characteristic of the red blood cell.
I gotta go. I've been working, told them please don't hit my phone. I'm in my zone, bruh, just leave me alone. Was on the road, but I swear I'm coming home. Now the drinks on me, I think we need a toast. See, I did it for me. Now my old friends calling, told them nothing's for free. Told me time is money, dog, swear I paid all my fees. I was starving for this game, now my family can eat.
Hey everyone, welcome to the Cup of News episode with your hosts, Peter and Matt here. Thank you everyone for taking time and tuning in on this amazing day. We're excited for this episode, as all of them, we're going to provide some value on these Cup of News episodes. So if you find any value in these podcasts, like them, learn something, gain some knowledge, please share with your loved ones, your friends, family. This is what motivates us. This is what grows. We get downloads, the algorithm picks us up, and that's what motivates us ultimately to keep on producing this high quality content. By the way, Spotify has ratings out now. So if you're a Spotify listener, go on there and give us the rating that you think we deserve. 5 stars, by the way. And same thing for Apple. If you're on Apple listening, hop on to Spotify really quick. Slam that 5 stars for us, because that is going to help us out. Cup of News, episode 81. I'm pumped. So for any announcements and anything related to us. Oh, one more thing. Spotify finally has videos out. So during the time of this episode, you already should have video podcasts. So if you're listening to Apple, you might want to jump onto Spotify, because you actually could watch us at the same time as you're listening. So for those that are Spotify or Apple listeners. By the way, Cup of News or cupofnurses.com for show notes, anything related to this episode, announcements, and anything in the future that we're releasing. And if you're more about the consciousness, self-improvement, we are Frontline Warriors. We have blog posts on there that's going to motivate you and help you develop self-awareness. We got the vlogs coming out week by week. We just finished and wrapped up the Pacific Northwest. We're going to have some Chicago ones coming out and maybe 1 or 2 in Texas. So tune in for that. And of course, the big project that we're working on, pronto, we're going to be revolutionizing and innovating the healthcare industry. We're putting a lot of time into it. The website and the app should be out soon. So once the landing pages are out for signups, we'll make some announcements there and go from there, guys. How you doing, Pete?
I'm doing great, man. Another wonderful intro. Thank you for that. This episode, we're going to talk about blood, different types of blood, kind of how we administer blood in a hospital, and what's it actually made of. Because a lot of times we just associate blood with red blood cells, but there's more than that constitutes our actual blood volume. So for our blood, there's actually 3 components to our blood. It's going to be the plasma, the red blood cells, and then the white blood cells and platelets. So if you break it down to percentages, your red blood cells account for about 44% of your blood. Then your plasma is about 55%, and your platelets and your white blood cells accounts for about 1%. And it's something that people aren't really aware of, and you don't really find out about it until like you go into some kind of medical field or nursing field or any kind of like health science, you could say. Because when you go to a doctor's office, all they really do is draw your blood. They don't really tell you anything else about it. And then when your labs come in, they just give you your labs, and then you're basically out the door.
Yeah, but a lot of people think it's blue, right, from the interior because of veins and structures.
Right. Yeah, a lot of people think it's blue, and then when it comes out, it turns red. That's another way people see blood. But it's just like, it's a crazy thing that majority of people out there in society, and even some of our listeners here, don't know like these components to blood. And like when they go to the hospital and we give them like a unit of blood or a plasma, they don't even know, because when you think of blood, you think of something red. So in a hospital, if you give you red blood cells, we give you a unit of blood, it's red. But then if you give you plasma, it's more of like a opaque color, right?
Yeah,
and then same with platelets.
Yeah.
Right. It's all different colors. So and they're all considered, blood. So when we have like for example, a patient that comes in and he's like a Jehovah's Witness, they don't accept any kind of blood products usually. So we can't even give them platelets. We can't even give them any kind of plasma. We can't give them blood, of course, because they don't allow for that. So it's always interesting to look at blood in the hospital, you could say.
100%, brother. So the first we're going to start off with is with red blood cells. So the red blood cells they're called erythrocytes, and they make up 44% of the blood, just like Pete said. And just envision them as being this roundish cell with a nice little donut in the middle. And the size, the shape, it all matters to the overall health. And I first discovered this even before getting into nursing when I was sick in Poland. And what happened is I went to a Chinese doctor and he took like a needle instead of like the glucose test, and he took a poke of my blood and he put it under a microscope to see the shape of my red blood cells. And he told me, long story short, appendicitis, and I was on long-term antibiotics, which for some reason messed up my not immune system, but my gut, which I had to treat naturally. So he literally looked at your your microbiology and told you what's wrong with your body, what are you deficient in, based on the characteristic of the red blood cell.
Yeah, and even in nursing school, in our nursing books, there was different types of red blood cell abnormalities, and it shows you that some of them are concave, some of them are, what's the other word, concave and convex.
Yeah.
And that's obviously like a mutation and like an issue with your blood, which doesn't allow it to function properly. The main function of blood has two main functions. One is to take oxygen from the lungs and distribute it throughout your body, and then the second function is to take carbon dioxide out of your organs and put it in the lungs. That way you could exhale it and you could breathe it out, so you could function normally, maintain the pH balance. But looking at blood under a microscope, if it's not round, if it's irregular looking, then that's going to lead to usually some type of anemia, some kind of issues with your red blood cells. And not only do they look at the shape of the red blood cells, they look at the nutrients that you take in from your diet, because red blood cells don't just pop out of nowhere. They're made by the bone marrow, but they require certain things, and the major things that they require is folate, iron, vitamin B2, B3, and vitamin B12. So you need all those to have efficient and appropriate looking red blood cells, because if you don't, you can't perfuse your organs properly. And it's interesting, I actually found out about this while doing some research over here, is that your red blood cells actually lives 120 days. And if your blood cells are diseased or irregular, they don't live that long, which leads to different types of anemias that you can experience, which can cause low red blood cell count as well as poor perfusion. It could impact your blood pressure, and it could impact your heart health, your kidney health. It could literally impact all your vital organs, because blood flows through all of that.
Yeah, and that's interesting, because sometimes in the hospital we don't like transfusing unless it's less than 7, but technically that's already a state of anemia. So I feel like if some of these patients we gave like a blood product, it would help them so much more, because they would have, like the C19 patients, you got hemoglobin that's like 7.8, but they can't get their sats up. Well, if we just dumped in a little bit more RBCs in there, that would help them out. I first kind of realized this when I was in working in LA with the whole ECMO team, where there was research that came out that said you should transfuse if you're 10 and below. And it helps with the mortality and the improvement of the ECMO machines, and that's why they do that.
Yeah, I know, like with my experience working at the heart units, we like to keep our patients, like you could say, as fluid volume depleted as possible. So I can understand why they wouldn't want to give blood to someone that's like in like really bad or in certain type of heart failure, because every time you give a unit of blood, you're increasing the volume. And if you have a poor heart, let's say you give a unit of blood, and that unit of blood accounts for like 250 mLs or 300 mLs or whatever, it says on the bag, that could literally be enough to throw somebody into like pulmonary hypertension or fluid overload, and it could do some damage. So that's why I understand that some units are kind of a little bit more picky and anal about it. They don't want to transfuse if it's less than 7. I understand that portion, but it makes a valid point. Like sometimes I look at patients, I'm like, I feel like this patient could benefit from a unit of blood, even though their hemoglobin's like 8 or whatever, above 7. You're still like, maybe this might help them out. They're like a little on the hypotensive side. You've been holding your beta blockers or whatever, and the fluid volume is decent. Sometimes they might need that unit, but I guess sometimes physicians are just kind of more reserved with that. I'm not sure 100% why. I was thinking when I was doing this research was like maybe you know how if you give, like, let's say, for example, steroids, when you take steroids, like for fitness, and you basically get exogenous testosterone from an outside source, so you take something that's a pill or an injection that boosts your testosterone, your body is naturally going to not produce testosterone because it's getting from an outside source.
Yeah.
So I was kind of thinking, like, could that happen, But I feel like your blood...
Where your bone marrow wouldn't be making
Right.
RBCs or blood products because it already technically is artificially efficient.
Right, but then I'm thinking RBCs last for 120 days. So that's what, 3, 4, 6...
3 months.
Yeah, 3 months.
Oh,
So,
no. More, 120 days?
Yeah.
Because 90 days is 3 months.
Yeah.
Trying to do some quick math here on the
3,
show.
6,
We got 4 months there.
Yeah, 4 months. Yeah. So I'm thinking maybe that, but that wouldn't make sense because I've never heard of anybody of like getting like bone marrow suppression from like a blood transfusion,
Yeah.
So I'm kind of curious. I was always curious. Is it because, maybe blood is just really hard to find and they kind of want to conserve it at all costs? That might make sense too. Or maybe there's different ways that they could maybe stimulate the body, like with erythropoietin, stimulate
Those
the RBC.
injections, yeah.
Stimulate the RBC. But people don't really get erythropoietin at the hospital, really, especially in ICU.
Only the CKD patients
Yeah.
or ESRD.
Right,
And stage renal disease for those that don't know the terms.
Yeah, so only like a select few get it. So it's like, I'm not sure. That's actually another good episode that we probably should do on like a Friday. Why do we transfuse if it's less than 7 only?
Yeah, the benefits and all that. So since we're talking about anemia and that's an efficiency of RBCs, we're going to start with the first one, which is iron deficiency anemia. And we need iron, just like you mentioned, is one of the key minerals in order to produce red blood cells in the bone marrow. So if we're deficient in that mineral, we cannot produce any RBC, or you produce less RBCs and not enough. And this is why it's called iron deficiency anemia. Some causes of iron deficiency anemia is diet, which is low in iron. Eat your meats, vegans. No, I'm joking. Sudden blood loss, of course, with hospitalizations and an ongoing chronic blood loss. And this could be from heavy menstruations, different maybe surgeries, or some absorption issues and weight loss surgeries.
Yeah, I think also, I didn't include it, but I was reading something online that even the vitamin D deficiency can lead to iron deficiency anemia just because like the sunlight plays a role and then vitamin D plays a role in all this iron and vitamin like metabolism and stuff like that. Yeah, the second, you could say like a real common anemia is sickle cell anemia. This impacts usually the black population in the U.S. and in the world. You see this more in black people than white people. It's an inherited disease where your body produces irregularly shaped red blood cells, which then impacts the hemoglobin, which is built by the iron. So they have abnormal the hemoglobin that's in the red blood cells that carries oxygen, it's abnormal, and so is the shape of the RBC.
It's almost like a moon shape or like a crater. It's not circular. I'm sorry if I cut you off here, but it's like, imagine like the super highway, and there's like perfectly circular RBCs and blood products passing through, and they're gliding against each other. But now you have these moon craters that could like start clipping onto each other, and then when you're in the capillaries and fingertips and all these small little places, they get stuck. And as you learn in nursing school, these are the patients where, like, if they say pain is 10 out of 10, they're not kidding. They probably need some Dilaudid.
Yeah, when someone's coming in for like a sickle cell exacerbation, yeah, definitely Dilaudid, morphine. And then this is very common. A lot of the times it's asymptomatic, you could say, because not everyone that has sickle cell is always in pain. It's more of like when they have a sickle cell exacerbation that they really get these clotting in like their microvessels that really hurts. And people are like really, really in severe amount of pain. And what's also crazy is that it cuts down the life of the red blood cell by like a third. So instead of living 120 days, it lives for like 10 to 20 days. And then your bone marrow, has to reproduce the RBCs, but it's also reproducing these sickle-celled RBCs, which is, it's a continuous disease. And it sucks. I've had, I think, 4 or 5 patients in my nursing career that had sickle cell, and it sucks. It's just you're giving them, I basically was treating them with morphine and just giving them blood. And that's basically until the body just kind of relaxes and normalizes, where the normal RBC production and circulation is higher than the sickle-celled RBCs.
Yeah, and what's fascinating about that is because your body identifies these RBCs as being irregular, they get broken down quicker, just like you mentioned, and this could lead to organ damage because your bilirubin is going up, your lymphocytes are being overstimulated because you're trying to break down and recycle these poor RBCs.
Yeah, because like real quick, just because when your body breaks down these RBCs, like the spleen or the liver, it could usually reuse whatever it breaks down. But just like with anything, like when you're recycling material, even like, in like the real life perspective, like a recycle can, you don't always reuse everything. Some of it still goes to the trash, and that just raises your pH and just messes with everything else.
Yes. The next anemia is normolytic anemia. So this means that your body is naturally producing RBCs, but just not enough. They're normal shape, normal size. Your body's just not producing enough. And this is usually related to diseases such as kidney disease, cancer, or rheumatoid arthritis that's causing this normocytic anemia to happen.
Yeah, the next one is like hemolytic anemia. This is one of the rare ones, you could say. It's usually due to some factor that causes you to break down RBCs. So a common situation where you might see hemolytic anemia, I've seen it quite a bit working with LVADs, because no matter how healthy you are as an individual, when you have an LVAD in, you're going to have some kind of hemolysis going on. It's not going to be real severe, because when it does become severe, it usually results in a hospital visit. But every time you have a artificial mechanism or some kind of machine in your body that's not meant to be in your body, you could say, your RBCs are getting destroyed. Even with like ECMO, you're getting some hemolysis with ECMO, because your body, the blood in your body is coming out of your body, it's going through a machine and getting pushed back. So just having that artificial like machinery, that automatically impacts your red blood cells, and you're always going to get some kind of a destruction. Even with dialysis, you're going to get a little bit, not a whole lot, because dialysis, it's usually not enough to have you go into like hemolytic anemia where you need blood products and you're on the verge of dying. But it does cause a little bit of this. But mainly you see this with like LVADs, and yeah, it's when someone is in like a hemolysis state, it's very intense, because they're in a lot of pain, and it's not with an LVAD. There's not a lot of things that we could do, because the solution to getting rid of this hemolysis in an LVAD patient is to turn off the LVAD. But you can't turn off the LVAD, because that's what's making the person's blood circulate the body. It's working as like a pump for the heart, which is very intense. When somebody goes, they start peeing out blood. Their pee is brown and red. Then they start going to DIC. It's a fucking mess. This is a scary one, but you don't see it that much.
That's why it's like a end of life measure, basically. Yeah. The last one, which is also not as common, is a Fanconi anemia. And this is a rare inherited disorder that's basically your bone marrow is not able to produce blood components, including red blood cells. So this is more genetic. It's in children, and it starts with this children is born with a serious birth defect, and it may develop into leukemia.
Yeah, it's unfortunate. Yeah, like straight from birth, there's some issue going on where you cannot appropriately produce these RBCs, or you're producing them in like an irregular manner, and you can't develop properly, because if you're not perfusing your organs, how are you supposed to grow? And it's a very sad thing. I think it's something that we recently found out about not too long ago, and there's a lot of research studies that's being done on it, but not a lot you could do, unfortunately.
Yeah.
Especially if you have like a disease like right from birth, like it sucks, or you have a disease when you're in the womb, because you're developing there. Like this, when you're growing as like an infant, as a child, you're going through so much growth and development in different areas that any kind of thing that throws you off, it's going to impact the developmental process. Like it gets crazy. Like we listened to a podcast one of these days. It was with I don't know who the doctor was, but they were saying that when this is not about blood, but this is still kind of ties into like the development process of a child. I told you about it like maybe months ago, where we were listening to a podcast, and there was a doctor on that said that there has been an increase in the amount of like jaw deformities in children.
That's right. I
remember. And they're associating that to the fact that we have been introducing baby foods to children for such a long time, where it's causing this. Because back in the day, there wasn't like baby food where it's like soft and all they really have to do is swallow it. They had to do some kind of like more jaw action, and they're saying that this increased amount of baby food, instead of like you could say raw or more organic foods, leading to these jaw deformities.
Which makes sense why there's a rise of orthodontics, people not having their teeth straight. And it makes sense. Use it or use it, just like exercising a muscle. So when you're developing, you need to be eating something to stimulate your jaw muscles and your bone there in the mouth to form. Right.
Yeah. Just like imagine if like from the age of like 4 to age of like, 6, or I'm not sure when children eat baby food. I'm not that.
Yeah, throw them a bone at like age of 5 to make sure they don't get braces.
Yeah, see what they do, And imagine like sucking through a straw for while you're trying to develop your jaw. Your jaw is going to get developed to sucking a straw, not to necessarily chewing on foods, right? So yeah, it's a little fun fact for y'all.
Fun fact.
Yeah.
Different types of blood types that we're going to go over now. So there's 8 total. Let's start with A, B, AB, and O. So those are the main 4. And then once you get into the RH factor, which is either you're positive or negative, that totals into 8. So always very fascinating. I always had a hard time struggling understanding this in nursing school.
I think a lot of people do because it's confusing. It's like because a lot of these words sound the same, and it's just like blood, and you associate blood with just being blood, right? Not these like A, B, all these letters and numbers now.
Especially when like they made us like write out a graph to see who's compatible, who's the universal donor, recipient, and all that. But I never really understood why that is. So we're going to explain this to you, and hopefully after this, you don't have to write graphs for blood products. You'll just understand it. And if you're already a nurse that's listening, you probably don't have to even worry about this because the blood bank just hands you the damn blood. It's already cross-checked. You just scan the damn thing, and you're good to go. Right. But it's also a good refresher.
100%.
So we have the antigen, which is all RBCs have them except for type O. So the antigen is literally like an immune. It's like an immune response that contacts the antibody that there's something irregular come and destroy it. So the antigen is hooked up to the actual red blood cell, and then we have the antibody, which is an antibody in the plasma. So it's circulating, and it's part of the immune system that kind of attaches to the antigen, stirs up a lot of things. And fun fact that every blood type has an antibody except for type AB. That was very fascinating. I have never knew till doing some research on this episode.
Yeah. So when you think, because it's a little confusing. So like for all you nurses out there or medical professionals that are doing exams and stuff. So when you hear blood type A, B, AB, and O, so that's usually referring to the antigen on the blood. An antibody is a thing that's circulating. So if you have type A, you have type A antigens. If you're blood type B, you have B antigens, and so on and so forth. And yeah, it does get confusing, especially right off the beginning when you're trying to slowly learn about this. But once you kind of practice it more and more, you kind of start to understand and realize that hey, this isn't the hardest thing to memorize in the world. So regarding a blood type A, so it has only A antigens, and if you have blood type A, you're going to have B antibodies. So you're pro A, and you could say you're against B, for example. So that's why when you get blood, you need to get type A blood or also AB, because you could only get the kind of blood associated with what antigens you have, because think about it as like two magnets. When you get two negatives, they push from each other, right? But when you do have a negative and a positive, they stick together. So for example, let's say A is a minus. So your blood type is A and you get A. They don't stick together. But if you're blood type A and you get B, well, guess what? B is a positive. So now you have a negative, which is the A, and the B is a positive. And what happens when you have opposite charge? They stick together.
Yeah.
And they fight each other off, and they end up destroying themselves and breaking it down. And you can't live like that. You get into a reaction, and it's very detrimental. You start getting fevers. You start getting tachycardic. You start turning red. Your blood pressure might drop. It's a whole mess. Of course, not everybody has a really severe reaction to it. Some people might have like a small reaction where they just get a little bit red, and usually physicians are okay with you getting that. Maybe they'll just give you Benadryl, and then that'll kind of treat it and alleviate it, because sometimes we need to give you blood, but you happen to be one of the lucky ones where you have a reaction to your own blood type when you get it, just because there's like other micro things in there that people react to. That's why it happens, unfortunately. So sometimes we just give you the same blood, even though you have a little bit of reaction, we just give Benadryl, and we'll kind of finish it off with that. So yeah, so regarding if your blood type is A, you could donate to A and AB, and you can receive blood from O, and you can receive blood from A. And then for blood type B, you have the B antigens, so you could donate to a person that has B blood or AB blood, and you can receive blood from a patient that's O and B as well. Okay. So a lot of this is just kind of mix and matching the opposites. So AB and O kind of get a little bit confusing. So blood type AB, it has both A and B antigens, but you don't have any antibodies at all, because if you had A antibodies, guess what? It would attack the A portion of your blood, and if you would have B antibodies, it would attack your B portion of your blood.
And this is a good way to think about it, because you have no antibodies in the plasma, and plasma is already circulating throughout your body, you can receive almost anything. You're that universal recipient
Yep, the beauty of it.
Yeah.
It's kind of crazy how that works too.
And blood type O, so that one has no antigens on its surface, but it has both A and B plasma antibodies. I'm sorry, no antigens on the blood, so O, but on the plasma it has both A and B antibodies. So you can donate to anybody, meaning you're the universal donor, but you can only receive O because you have antigens to both A and B. So that's the beauty of blood type O is you can give, but you could only receive so little.
Right. And if you thought that was complex, it goes a little bit of a step further because now we also have RH factor, and that's usually positive RH factor or negative RH factor. And kind of the same thing goes with whatever you learn with the blood, is that if your patient is RH positive, they can receive positive and negative blood. But if they are negative, they could only receive negative. So that's kind of another thing. So if you give, let's say you're A negative, you can get A positive blood. You're gonna have another reaction, and you're going to do more harm than good. Crazy how much things go into. I think RH factor is something that we found out just recently, you could say, like I think within like the last like 20, 30 years. Because back in the day, people were matching blood, but then people were still having reactions. Like they would give, it was just A blood. So patient A that's A blood would get A blood, but they didn't know about the RH factor, and they were still getting reactions. So then scientists were like, why are people still getting reactions? Like this blood matches their blood. Why are they still, getting these kind of, you could say, not withdrawals, but like what do you say when you refuse something? Another word for that, rejection. So it's like, why is this A patient rejecting this A blood? And then they kind of did some more digging, more research, and they found out, oh, hey, there's another thing. It's almost like another antigen, you could say, the RH factor. A little bit confusing, but it's a little bit simpler, just positive and negative.
Damn science.
I know, it's crazy, dude.
So the next thing we have white blood cells and platelets. So white blood cells account for only 1% of your blood. That's fascinating, but they're just circling around in the three different fluids, and they're just monitoring and making sure that everything's going according to plan. But they have different responsibilities, and we're going to break down the 5 main types of leukocytes, aka white blood cells. So the first ones are called neutrophils, which accounts for 62% of all white blood cells. They're responsible for fighting bacteria and fungi, and they only live for about 6 hours to a few days. Normally when and I don't do this often because you're just so busy, you let the doctor kind of worry about it in a way. But if you're looking at a CBC with a differential and your neutrophils are elevated, they call them bands, I think, right? If there's like a 10% band increase, that's a sign of a potential acute infection. Because usually those neutrophils don't last a while, but if your immune cells around the body are saying, hey, there's an infection, your body's going to start stimulating these neutrophils from formulating and start fighting off the bacteria wherever it is.
Yeah, that's cool because these live anywhere from like 6 hours to a few days. And it's crazy how this works. If you have like a few of them circulating, and then when there's like a perceived threat or an infection, your body produces more, and maybe you only need them just for a couple hours. And then, they're alive for a couple hours, and then they get recycled and reused. It's a crazy mechanism. The second most populous white blood cell is going to be your lymphocytes. It's about 30% of your leukocytes are lymphocytes. And there's 2 major different types of lymphocytes, you could say, your B cells and your T cells. B cells, they're responsible for like your antibody reactions, and they're also responsible for activating the whole T cell cascade. T cells are a little bit more complex. There's different types of T cells. For example, there's cytotoxic T cells, which those are like your major cells for destroying any kind of viral or cancerous infection, you could say. Then you have the helper T cells. What they do is they activate the rest of the T cell cascade. They also help with activation of macrophages and also other B cells. Then we have regulatory T cells, which regulates the T cells, which means that once the infection is over, you don't want to still stay in that heightened immune response and keep producing these white blood cells. So the helper T cell or the regulatory T cells actually help suppress the inflammation and immune system and help you kind of rev down and relax and let the body know that, hey, infection is now over. Then you have the memory T cells. They protect you against prior infections. They're the ones that store all this immune memory. That way, if you get a cold and happens to be the same strain of cold as before, your body's gonna know how to fight off already because it already has it somewhere in its library. And then your natural killer T cells, they're like it says natural killer cells. They're just there
Navy
to just
SEALs, baby.
Yep, they're just there to destroy. If the cell does not have a certain marker that's associated with you, it's going to get destroyed. Sometimes it does lead to some casualties and stuff like that, but these are the heavy hitters. These are the ones that are dropping the bombs, because you have to fight out this infection, and this is almost like your baseline reaction to just let's whatever is infecting us, let's just destroy it and hit it as hard as we can. I know some good cells might get destroyed, but that's sacrifice for the better good.
Yeah, it's wild. It's just so fascinating how beautiful our body is, immune system, and we're on the circulatory experience here with the blood. I feel like I'm literally taking an experience in the Magic School Bus right now, just learning about all this. And when you're talking about it, I'm just literally envisioning myself on the trip in the Magic School Bus, just seeing these blood cells and freaking white blood cells, T cells just circulating around and all that.
Yeah, the Magic School Bus, it made me like fall in love with science.
Yeah,
just because like you don't see this stuff, but yet it exists, and it was just like a really cool way to learn as a kid. You just watch the cartoon, and it was like action packed. There's always something going down, and it was really interesting. It probably taught me a lot before nursing school,
especially if you're like a visual learner. So the next one are monocytes, and they comprise 5.5% of all leukocytes. And we're gonna think about these as the macrophages. These are the bigger white blood cells from all of them, and they literally swallow microorganisms. They remove dead cells, and this is why. Side note: this is why. And this is something a little bit more new, where they're saying that atherosclerosis is not necessarily from eating meats and saturated fats. Let's just say if you're eating a diet high in sugar, these macrophages are destroying the extra sugar because they're cleaning things up in a circulatory system, but that's producing cytokines, and it's causing scarring on the endothelial cells, which is causing this atherosclerosis plaque to build up.
Makes sense, because it's causing inflammation, and inflammation is immune modulated, you can say. So it makes complete sense. So easy on those sugars.
Yeah, and then during inflammation, these cells actually boost immune responses by showing antigens on the surface of where to basically go. They're like the markers that get that. I'm trying to word this properly. But they release antigens, so your body knows where to stimulate that immune response.
The muscles are cool because they play like two roles. They play a role in like destroying the like the infection, and they also play a role in like identifying where this infection is and who to fight off. So it's probably one of our like very diverse. It has a lot of diverse functions for a white blood cell.
And the next one is the eosinophils, if I've been pronouncing that right. It's 2% of all leukocytes, and they're responsible for fighting larger parasites, and they're part of the allergic inflammatory response. For example, if you're sneezing and all that, they live up to 8 to 12 days. And the next one, because it's kind of related to the allergic response, is the basophils, which is just 0.5% of all leukocytes, and they release the histamine released during inflammation.
Yeah, and the histamine, when you have allergies, when you're sneezing a lot, when you have teary eyes, when you go to the store and buy medication over the counter, you're usually buying antihistamines, because histamine release is responsible for those teary eyes and those sneezing, because that's another way where your body gets rid of the infection. When you sneeze, you sneeze out the infection, you're kind of decreasing the viral load, you could say, of the body.
Yeah. And just put this all into perspective, it's very fascinating how our immune system works. And it's truly magnificent. So if you think about it, you have a cut or an infection that takes place. Okay, you have some neutrophils that come in there and they're fighting the war. But hey, they're just the babies of the immune system. They need some help. The lymphocytes come in. They really take care of business because they're the Navy SEALs, the T cells. And then you have the macrophages who will kind of come in there. They could kind of clean up the mess, also swallow up some microorganisms. And then you have the basophils that come in that stimulate a inflammation response to help vasodilate, bring more nutrition into that area, and help stimulate everything. It's full circle. It's beautiful.
When I was reading this over, I'm like, the immune system is super complex. So I could almost kind of understand why, if you don't live a healthy lifestyle, because I'm sure you guys have heard us preaching before, is that majority of your immune system is in your gut. So if you have a poor diet and you just have a poor lifestyle, look at all these different parts and systems in your immune system, and imagine where these things could go wrong. So if your body is not in like optimal shape or optimal performance, bad things could happen. Like you say, if you have high blood sugar, you start having these white blood cells attack your sugar and it cause inflammation. They could lead to oxidative stress and all that stuff. So it's a very, very complex system, and that's why it's important for you to stay as healthy as you can all the time, because these cells, they don't have brains where they could think and say, hey, this is enough. They're just going to keep doing their job over and over and over again, right? Like imagine like digging a hole. If you keep digging a hole, to like, let's just say put a foundation, and if no one tells you to stop digging, you're gonna keep digging and you're gonna get water. Or or if you dig super deep, maybe some like volcanic plasma or something. I don't know. You gotta be careful,
And
same way.
Just to give a little perspective too on what you just mentioned about the whole autoimmune thing. This is why autoimmune disease can happen, right? Because you can't identify yourself. And it's the same way like bees, for example, that are getting hurt by all the cell phones and all the radiation that they're experiencing, and they can't properly do their function. Same thing with like the geese, if they're traveling and using electromagnetic frequencies from the earth to know where their breathing grounds are. But now that's being disrupted because of whatever technology we have coming out. Think about it the same way, where if you're eating shitty food, there's going to be a disruption in the genetic information that's telling you how to do your damn job. So if that signal gets disrupted, they're going to continue doing their job, but they're just going to start attacking each other. And they don't know that they're friends all along. They just got the wrong signals, wrong information,
Right. Yeah, it's wild. So another thing that composes that 1% of blood that we mentioned is platelets. So platelets range from anywhere from, I'm pretty sure it's like 150 to 450,000. Usually when you look at like a lab, you see like 150 to 450. Usually we kind of don't use those big numbers because it's easier to look at. And platelets are thrombocytes. They're also made in your bone marrow, and they're responsible for clotting blood, making sure you don't bleed out. So when you get a cut on your hand, a scrape on your elbow, platelets are responsible for stopping that bleeding. They played a major role, but it's also sensitive. It's a very sensitive thing because if you have too much platelets, it's going to lead to overclotting. But if you have too little platelets, it's going to lead to underclotting, and it could be a detrimental issue. We see a lot of people in the hospital that have a lot of clotting issues, and even in a hospital, per protocol, we always give either heparin sub Q, or we put them on SCDs, or we give them Lovenox, or just other kind of antiplatelet things, because we want that in a very standard range, because when it's out of the range, things could go wrong very, very easily. And if we have, for example, like if you're more prone to clotting, then we would want you to have less platelet aggregation. That's why some people go on like antiplatelet medication at home, because if you have like a poor heart or poor kidneys and your blood is stagnating, like the man mentioned with the RBCs, they only know one job. The white blood cells only know to fight off infection. Well, guess what? Platelets only know to stick together and stop bleeding. And sometimes if you have low blood volume, or you have some issues that lead to increase in coagulation, guess what? You're going to be more prone to having like a stroke or an MI, because they're going to pull together and clot, and they only have that one job, and they only know how to do that one thing, and it's to clot.
Yes, and this is why you take medications such as aspirin or Plavix when you're getting a stentin, because it just makes these platelets a lot more slippery, I would say, and they're not going to form these clots that you're just talking about.
Yeah, and then if someone has low platelets, we call that thrombocytopenia. Usually if something ends with penia, it means like less or lower. So that's why we kind of associate thrombocytopenia with lower platelets. And this is usually when you have like 10,000 to 20,000 platelets circulating around in your blood. Usually you see like 10 to 20. But what's crazy is that we had that one patient a couple weeks ago that had the idiopathic thrombocytopenia, and her platelets were like a 2.
Yeah,
that's crazy. And we ended up intubating that lady. And when we were intubating her with the NP, when he was going down to put the ET tube in, he already saw like little microbleeds going on. And he was like, let's make sure I do this right, because if I happen to nick something, it's going to be a really big issue. Especially if you nick something going down the ET tube, you're gonna bleed into your lungs, and you're gonna die. You're just gonna choke on your own blood. So it was cool. It was interesting seeing him go down with the ET tube, because they had the little camera, and you literally saw just like red dots literally everywhere. And he's like, oh, we gotta watch out for that. Yeah, so you just gotta be careful. And we check your platelets every day. It's part of our standard routine. CBC, when you go to get your blood drawn at a doctor's office, when you get a CBC, the platelet count is part of the complete blood count.
Yeah, I was taking care of a patient too where she was in sepsis and had a whole bunch of issues going on. But what was fascinating is she had IDP as well, idiopathic. They don't know the source of why she has low platelets. But when what I noticed is she was septic. They put her on like two, three different antibiotics. One of them was Vanco. They kept switching things around because they didn't know what was happening. And her platelets dropped from then. So they think that it could have been sepsis, multifactorial with maybe antibiotics that causes from happening. Another fascinating things I learned about plasma is, you know how, and I learned this from the STICU in the shock trauma unit, where you could pressure bag blood. She's like, yeah, we're fancy here. We don't put it in the pump. We just pressure bag things. I'm like, okay. But she's like, don't do it to platelets. And I'm like, oh, interesting, because I never pressure bag platelets to begin with. But if you pressure bag platelets, they're just gonna break down, and they're so delicate that you want to just hang them and free flow them into the body.
Damn, I didn't know that. That's interesting. Yeah, dude, look at that. Dude, travel nursing has taught us so much. Who would have known? You know, maybe one day if we would have known, we would have been like, okay, platelets are like at a 0. We got a massive transfuse platelets. We gotta squeeze it in there.
Dump them.
Yeah, it's like you can't. You gotta make it just nice and calm.
And they're gonna look at you like, are you stupid? Nah, man, I learned this in a shock trauma unit. What are you talking about?
Right.
But you're just a nurse. Mother.
Yeah, so on the flip
Play out
side.
that scenario.
Right. So on the flip side, we have thrombocythemia, which is the overproduction of platelets, and that's usually anywhere from like 500,000 to 1 million. And this can lead to overclotting because you have more platelets. So you might have a higher chance of stroke, higher chance of MI, higher chance of any kind of DIC going on, just because you're overproducing these platelets. So you're going to start clotting in places that you don't want to clot. And I haven't really experienced a patient that has high platelets. It's usually the opposite, I feel like, for me. I'm not sure if you have any experience with high platelet patients.
They were high, but we didn't do anything specific to treat them or anything. Really just Lovenox, man, or heparin, right? That's all they really do for that.
Yeah, with platelets, I feel like you have a little bit more wiggle room, because sometimes you have a patient that has platelets of like 8, and they'll be like, okay, just be careful. We're not gonna give them platelets yet. Well, or hopefully they're going to come back up. We don't treat it super aggressively.
Yeah. So the next one is thrombocytosis, and this is another condition where you get.
It's also, you have still elevated platelets, but this is because your bone marrow is overproducing them. For some reason, your bone marrow is producing too much of these platelets, usually associated with cancer. When somebody has like almost, you could say, idiopathically high levels of platelets, it's usually associated with cancer or some kind of a disease in a body that stimulates this platelet production. I never heard about it before until this time.
Yeah, I looked at it because I didn't read that one too well, and I'm like, wait, what the heck is this? Because cytosis kind of reminds me of
like breakdown
of something, and it completely confused me. And I'm like, okay, I'm gonna try to scramble around and try to figure this out.
Yeah, it's very complex. Like this is just blood. So for all of you people that aren't medical professionals or don't work in the medical field, like we're just talking about blood. And this is just how complex one aspect of our career and of our job is. So imagine all the other things that we have to worry about, like decay and things like that.
And I think this is why nursing is also a badass profession, because we're not only dealing with the heart or the lung or the kidney specialist. We're the specialist of it all in a way. We have to just know a little drop of knowledge in every single department. And that literally happens because you're the facilitator of your patient. When the kidney doctor comes in or the GI doctor comes in, like he's going to be asking what that doctor thinks or what are his recommendations. And that's where the collaborative work comes in of, who you are as a nurse.
Yeah, that's the beauty of being a nurse, especially you notice it a lot, I feel like, in university hospitals or teaching hospitals, because usually in teaching hospitals, you have a bunch of different specialties there compared to like a more community one where you might just have like a cardiologist and a pulmonologist and just like overall regular doctor. Maybe renal might stop by every so often. But with these university hospitals, it's a really good learning experience because you literally have psych comes in, neuro comes in, cardio comes in, and then maybe the surgeon comes in, then renal comes in, and then the pulmonologist comes in, and they're just focused on their one system. And you as a nurse have to know everything about every system in a sense, because the cardiologist is going to come to you and he's not going to just assess the patient and figure out things himself. He's going to ask you questions. So you got to know what blood pressure was, what the heart rate was, did they have any kind of tachycardias, any kind of arrhythmias overnight, are electrolytes okay? And then you have the renal doctor come in and say, hey, has he peed at night? How are his electrolytes? What's his volume status? Do we need to replete anything? How's his crean? And then you have the pulmonologist come and says, okay, we're gonna try and extubate today. How has he been breathing? Did you do a spontaneous breathing trial? And you're like, oh shit, you gotta facilitate all this. And for example, a cardiologist might like the potassium in the 4s. Let's just say you have a patient and potassium is 3.5. The cardiologist might come in and say, cool, let's give him 40 milliequivalents of potassium IV just to raise the potassium. And he's not gonna really always look at the crean. He just looks at his lights. And then you might be the one like, hey doc, I know you want to keep the potassium at 4. He's at 3.5, but guess what? He's on dialysis and he's scheduled for dialysis today. If you give him 40 milliequivalents of potassium, you're probably going to skyrocket his potassium through the roof because, like I said, he's not making urine. His crean is 5, so he's not going to be able to filter that potassium. He's like, oh, okay, thank you. Then we'll just leave it alone. Reach out to renal. So it's like you're facilitating everything because these, in an ideal, perfect hospital world, you would think that these physicians from specialties would communicate with one another, sit down.
Some collaboration.
So there's some collaboration, but it's not as much collaboration as you would ideally want. So a lot of times, renal doesn't really know what the hell cardiology is doing. Cardiology doesn't know what the hell renal is doing. Renal doesn't know what the hell neuro is doing. And you're the one kind of like making sure that everything is done appropriately without having one doc step on another doc's shoes. Because like I said, they'll usually only pay attention to one system. And that's good. I like that because imagine if you had one doctor figuring out the whole human body. There's so much systems there. Like me and Matt are just talking about blood. Imagine the doctor having to worry about blood, the heart, the kidneys, the lungs, and all of that. That's very, very overwhelming. And doctors see a lot of patients. They would give a lot lower quality of care if each physician had to focus on the whole body compared to if each physician had his own specialty. It's a very good thing. It's almost like you're looking at a body as a machine, which in most cases you should, but we kind of always forget the mental aspect as well.
Yeah, and love the patient, who they are there. The last component of blood is plasma, which makes up 55% of your total volume, and it's mostly water-based, and it contains all the nutrients for our body, such as proteins, glucose, clotting factors, electrolytes, hormones, carbon dioxide, oxygen. Everything is in this plasma, which is literally carrying nutritions and hormones to the body, that's in charge of metabolism, and it's responsible for different organs of getting the right stuff there.
Yeah, I feel like plasma is like the nurses of the blood.
Yes.
If you think about it, because it's responsible for so many different things, but doesn't have full say over everything. You know what I'm saying? You're just there making sure everyone's every organ satisfied, the pH is good, all this is good, and then your blood is making sure you're oxygenated properly, while the plasma is kind of just like there just to make sure everything's chilling.
Yeah, and plasma is also usually with blood donation, it's very simple. But plasma is the more complicated one when it comes to donating it. So one thing that I'm looking here is that plasma is in charge of receiving detoxified material, waste products, and actually excreting them. So when you're getting your blood donated, or plasma specifically, does it run through this machine that cleans it out nice and clean before you have to donate it? And I'm sure that's the process, which is
100%.
Just amazing.
I haven't given plasma recently, but if I remember correctly, last time I gave plasma, like how you get the bag of RBC of blood, it just says A positive, and this is what's in here, the blood volume. And when you give plasma, there's different ingredients in there, like almost like TPN. Like when you see TPN, you see like this much potassium, so much magnesium, this much lipids. Same with plasma, you're gonna have basically an X amount of each ingredient because there's so much that goes into the plasma. Yeah.
So one of the main things that it's in charge of, plasma, is the coagulation. So it's important to think about this, such as fibrinogen, thrombin, the factor X, anything that's part of the clotting process that makes you stop your bleed is plasma. It's also immunity. So blood contains disease-fighting proteins such as antibodies, immunoglobulins, and it plays a crucial role in identifying and neutralizing the pathogens. So I think your white blood cells also is traveling in this fluid volume of plasma.
Yeah. So you have, it's literally like a soup.
Yes.
Soup, yeah. A real cool thing about plasma also is that it houses albumin, which is a protein that maintains blood volume. Sometimes we give albumin. Let's just say, for example, you have a patient and and they're hypotensive, a little tachycardic. So you're thinking that they're volume depleted. They don't have enough blood volume. So you kind of have to give them some kind of a volume. But let's say I'll say they're in heart failure, so you want to really give them fluids because that's just going to make their heart strain and work harder. And you also notice that this person is very fluid overloaded. So their tissues are fluid overloaded, but the volume in their blood is depleted. It's a pretty common thing in heart failure where there's enough fluid in your body, but it's just not in your veins. It's in your tissues. So one thing that we could give in a hospital is albumin, which actually takes the fluid out of your tissues and outside your vessels and brings it in. So it's almost like you're giving somebody fluids, but you're not giving them a straight bag of 500 mLs of saline or a liter. You're taking the extra fluid that your body is sitting in and bringing it into the vessels. Like when we mentioned edema, when somebody has edema, it basically means that they have fluid in their tissues because maybe they have poor renal function or poor heart function. So the blood volume or the fluid volume escapes from the vessels and goes into your tissue because it becomes more porous because of what you have going on.
Yeah.
And albumin does the opposite, where it takes that fluid out of your tissues and brings it into your vessels, almost like naturally raising your fluid volume without giving like artificial fluid.
Yeah, I had that one time. Remember that I told the NP about it, like, hey, do some albumin, and it worked really well for them. And this is why it's also very important to feed your damn patient. This is why we put Dubhoffs in, NG tubes in, and start them on tube feeds, is because you need protein to stimulate your whole body, first of all, for metabolism functions, but also for the production of albumin and these proteins so you can maintain this osmotic pressure and not be leaking out. I feel like here in this hospital in Austin especially, we don't look at that albumin. It's always low, but it can make such a damn difference, especially when the ventilators is causing edema to happen because of the gas exchange. Why don't we make sure that level is elevated?
Yeah, I feel like I like giving albumin, to be honest. I don't know. I noticed, yeah, it does work. It does work. Yeah, in heart failure patients, we always give albumin. We never gave fluids. We always try to give albumin first. But of course, sometimes people are so sick where albumin just doesn't do enough. I mean, you gotta give them fluids, but that's a really hard thing to do with heart failure, give fluid, because literally like 500 mLs of fluid can literally throw these people into like cardiogenic shock. And it's crazy to like see how that happens, or it can throw them into like pulmonary edema, and it's wild. Another thing that plasma does is it maintains your pH balance, as well as it's also the major transporter in your blood. So when your white blood cells got to get somewhere, they travel via plasma. Plasma is like the highway, you could say. It houses all your electrolytes, like Matt said, it houses all the nutrition, the coagulation things, and that's the main vehicle of these you could say micronutrients, or these factors are in your blood to travel to their desired location. It's also there for temperature regulation as well. Fluid shifts cause heat gain and heat loss, so plasma also helps kind of balance that out as well. So yes, very important components of your blood. It's crazy.
And this wouldn't be a blood podcast episode if we would be talking about blood administration. So
fun.
We're briefly going to talk about that and give you guys, I don't know if there's any really tips and tricks here. It's all very universal, but most importantly, follow your policies and procedures that the hospital gives to you. But there's just like some standard things to really think about. Usually there's a band that's on your patient, and it's I think it's universal. All hospitals have it. For some reason, when I worked in the STICU, that patient didn't have a blood band, and I asked them about it. No, that's fine. But and I'm like, was she typed in screen? Yeah. Okay, well then that's fine. Doesn't matter. But usually it's like my mental thing. Like if they don't have that freaking band, I'm not giving blood. But every facility does things differently, I guess.
Back in Chicago, we never had like a blood band either. We just would scan it normally, but they wouldn't necessarily have a blood band. You know, they would have a wristband that says like blood on it, but it wouldn't be like, it's a general band, like a fall band.
Yeah, so what I'm thinking now is every single healthcare system is different. For example, Meditech doesn't require you to scan the blood bank ID number. There's other facilities. When I worked in LaGrange, when I worked in all over the place, like in LA, you have to scan the blood bank ID before you give the blood product. So that's like that safety mechanism that they do. But before you get that blood band, you need to be typed in screened. So the type in screen allows you to get the blood bank ID. And that's just what we just talked about this whole podcast about the antigens, RH factor, you have to realize what the patient has before you give it to them, so you're preventing the transfusion reaction from happening. Some patients that have like specific antigens or RH factors, blood bank's gonna call you and like, hey, this is gonna take longer to get blood. So I don't know what the scale is of what's like the hardest blood to obtain or not, but the more antigens and RH factors that the patient has, the harder it's going to get blood depending on your area and all that.
Yeah, 100%. Yeah. And when you're about to give blood, you always want to have it with saline. You don't want to give it with like LR or any kind of other solutions, just because saline is the most similar to like, you could say, you know how we do the fluids like hypertonic, isotonic, all that. It's the same, closest to blood as we could get. So we don't want to give like a really super hypertonic solution or a really hypotonic solution, with blood. We just want to give the saline. So when you hang blood, you always have like the tubing is always has two places where you stick into the bag. One's gonna be for the blood, and one's gonna be for the saline. And you prime it with the saline, and then you add the blood to the chamber, and you basically let it run. So usually hospital standards, like Matt said, require a tuner's verification, and you gotta scan it, and then actually make sure that it is the correct blood. Because there could be times where you might scan it and might scan fine, but it might be like the wrong patient, wrong number on there. You just want to make sure everything matches up, because this could literally kill somebody. And once you get that set up, you want to take a baseline vitals of the patient, so you know where they stand. That way, if someone becomes hypotensive, you're gonna know that, hey, this patient was 110, now he's 80. Someone might be going on. Or if they're like 90 off the rip, maybe they just stay low. Maybe a change from systolic of 95 to an 88 might not be a sign of a reaction. And then you want to stay bedside for about 15 minutes just to monitor and make sure that the patient is doing okay. You also shouldn't start the blood to run very fast. Start it at like maybe 50, and then once they're okay, you bump it up to 100, 150, and then you do have about 30 minutes to start the blood. So it means if you pick it up from a blood bank at noon, that blood better be running by 12:30. And that blood could run for about 3 hours. So you have about 3 hours to give that unit of blood, and then you can give another one if you would like to. And usually this varies from the hospital. So you want a baseline set of vitals, set of vitals 15 minutes after you start the administration. And then the in-between stuff, it's more facility driven. Usually the facility that I've worked at, usually like a half an hour and then an hour, and then you're usually good for the most part. And then you want to do a set of vitals after you administer the blood, and also an hour after, because remember that you just gave the blood, but the blood is still circulating throughout the body for an hour, and you can still have a reaction post transfusion, which could be real scary.
Yeah, all very good points.
Yeah. And I would say probably the major things to look for like a reaction to blood is going to be tachycardia, hypotension, they stop peeing, they get fevers, or like a red rash, or even a headache. Those are like the most common ones that you could see. And like you mentioned in the beginning of the podcast, person might have like a slight reaction. Maybe they might get a little bit red. Maybe they might get a little bit of itchy. And some physicians are usually okay with that because they need to get the blood. So they would supplement it with like Benadryl. And for example, for like our heart failure patients, like I said, it's always a volume thing. We always want to be careful of the volume, because any increase in volume is going to lead to an increased strain on the heart. And you don't want to throw them into any kind of like tachycardia, or throw them into like a CHF exacerbation or anything like that. So a lot of times what we do is we give the blood, and then we follow it up with some Lasix. That way, they keep the RBCs, but they're gonna pee out some more fluid. So it's kind of like you're making them wet, and then you're drying them out right away. Just because they need that blood, but you can't give them that volume. So we kind of just do like that kind of approach to it, or even albumin we would give sometimes too with the blood.
A couple tips that I'm picking up as I'm listening to this when you're administering blood is always make sure IV's panned. So give it a good 10 cc saline flush. Ask the patient if they're experiencing any pain. Usually a lot of people say AC and above is ideal in the ICU central lines, but of course there's plenty of times I gave blood through like a 22 gauge. So make sure that's good. And then also sometimes what I liked to do before is when I was running blood through a pump is I put 999 and run it really quick till it almost hits the tip, stop, and then press begin on my MAR to start that. And then also I remember the first time I pressure bagged blood, which was in Pasadena. I did it. This is my first time pressure bagging. I didn't understand how things work. I connected it to a really shitty IV access, and I pressure bagged it, left the room, and then it turns out like the blood stopped pouring because it needs more pressure. The volume depleted in the bag. So literally, I had to be in the room almost the whole entire time pressure bagging this blood in. Usually, that's not the case if you have a good IV access. But most facilities, they want it on a pump, and you're not going to be experiencing that issue.
Right. Yeah. And if you do find yourself in a situation where your patient does have a adverse reaction to the blood, you want to right away stop the blood, flush the IV. Don't pull out the IV, leave it there because you might need to administer some more medications. And let your supervisor know, let the charge nurse know, let the physician know, and let blood bank know, because they got to figure out why the reaction happened. Was it because the blood was not the correct blood, even though it was labeled as A, but maybe it was B inside? They got to figure out what happened there. And you can't just, even though the patient might need blood, you can't keep giving it blood, because you're having a patient's immune system fight this blood, which is going to lead to hemolysis and a complete destruction of RBCs, which is going to further decrease RBCs. So you want to stop right away, flush it with some saline, and then notify everybody as soon as possible. Hopefully they don't have a really big exacerbated reaction where they're super hypertensive, tachycardic, they become somnolent, they're not responsive. It could get that bad. We want to avoid it. So just, get there on time and just flush it and get rid of that blood off the rip.
That's why it's ideal to be with your patient in the first 15 minutes. And sometimes that you get busy, man. You got to go in between the room and check on something and come back. Hopefully you have a great nurse that could watch your patients while you do all that.
Yeah, you got to be careful, because as nurses, I feel like sometimes we take it for granted. And, I'll be honest with you, even though it says to stay in a room for 15 minutes, I don't always stay in a room for 15 minutes because I got other stuff to do. I do pop on them like a lot more often, but I was still, it's like if I have to help my other patient out in the next room, well, guess what? I'm going to have to leave for the 5 minutes. And I try to come back each time, but it doesn't always work out.
And ideally, don't take granted the power of subjective information. Like, ask your patient how they're feeling during this time. Before you might seeing a drop in vitals and hives pop up or itchiness and all that, maybe the patient is going to be experiencing different things, or shortness of breath all of a sudden. They're just not feeling themselves. They know how they're going to feel, and that maybe could be your first indicator. You never know. Right.
And if they are feeling short of breath, that's usually associated to like a volume issue, not always a reaction. It could be both. Don't call me on this one. You should still stop it just in case. But it's usually a volume issue. So if they're short of breath, usually just giving them some Lasix is going to help. I know working at back in Chicago, like I said, every time we gave blood, we always give Lasix. So every time we got ordered blood, we always had a PR in order of Lasix. And I'll be honest with you, there was a time where I gave blood and this patient was really unstable, with really bad heart failure. They go in surgery like the next morning, but they needed blood. So we kind of gave them blood, and there was Lasix order PRN, and then she became short of breath. So what we did was we literally stopped the blood. We gave him 20 Lasix IV, helped a little bit. So then we restarted her blood, and then she became short of breath again. And then we gave her like 40 of Lasix. So she literally got 60 of Lasix in within an hour, which is a pretty good amount, and that actually helped her. We got her hemoglobin up, we got her ready for surgery, but we had to critically think hey, the patient needs his blood before surgery. They got to get this blood, but they're so fluid volume. Unless you're overloaded, their heart is just so bad that any kind of fluid change impact them in that way, where they got short of breath. And this literally was literally short of breath. With our patient, that patient that we had that one day where that had to get up to take a shit, had to go to the commode, and he got up himself. So we're like, fuck, we gotta get him up.
Yeah.
This lady was like that. She was late. She was at 30 degrees, and she literally went, as soon as we started the blood, maybe for 15 minutes, maybe she got 100 mLs of blood in that 15 minutes, if that even. She literally tripod position, have breathing, dyspneic, short of breath, and that was just because that little bit of fluid, that's her.
That much.
And it was so fucking scary because we were literally in the room just trying to figure out what the hell to do. We need to do this because she's gonna die if you don't give her blood. And it was a trip.
It's wild what a poor ejection fraction does to you.
Dude, it was 10%, man, if that even.
All right, what a fascinating episode. Hopefully this was educational for a lot of people, and some people might have to re-listen, take some notes maybe, because this is jam-packed. And if you want a visual learning piece to this podcast episode that could help you, check out the show notes on cupofnurses.com. You could go, page by page or section by section and understand what we're talking about, maybe take notes. print out the show notes. I don't know, take it to class, tell people about the Cup of Nurses podcast. I don't know.
Yeah, 100%. Or you can just go ahead and ask us. You go straight to the source. You could DM Cup of Nurses on Instagram or send us a message on Facebook, and we're more than happy to answer all your questions. I know people have been asking us a lot of questions in the past, and we've pretty much answered most of them, unless they're like super, super complex and like based on how your school interprets things. Those obviously we can't really answer, but for the most general nursing questions, we pretty much got all the answers, or we'll help you figure it out.
Yeah, buddy. Guys, thank you for tuning in. See you on the next one.
Have a great day.
Peace.